Okay, we're going to open with our first session here, resolving the PSA Testing Conundrum. First up, we're going to introduce Dr. Jacques Carter. And Dr. Carter serves as senior physician on the medical service at the Beth Israel Deaconess Medical Center, is an assistant professor of medicine at Harvard Medical School. He is also the medical director of the Prostate Cancer Screening and Education Program at the Dana-Farber Cancer Institute in Boston. In addition to patient care, his other hospital-related activities include teaching medical students, serving as a preceptor for a residence clinic, acting as a liaison for various community health programs, and serving as a member of the Internships Selection Committee. Dr. Carter has twice been nominated for Harvard's Prize for Excellence in Teaching. Ladies and gentlemen, Dr. Jacques Carter.
Thank you very much.
Thank you, sir.
Good morning. So we've got a short period of time this morning to sort of touch on this issue, controversies about screening. And I'm going to start, and then Professor Benjamin's going to come up after me. And both of us will be around for any questions, but it's just a small piece of this program, but we want to get this going. This will lay some of the groundwork for some of the talks that are going to be going on later. Can I have the next slide, please? So we sort of call this a conundrum, because as most of you know, there's been a lot of stuff in the press about to screen or not to screen. There have been a lot of controversy about various guidelines about screening. Some people say don't screen, some groups say screen, some groups say screen this group, screen that group. And if you are a clinician, certainly primary care doctors who do a lot of the screening for cancer in this country, you don't quite know where to go. So that means that in any particular situation, in any particular institution, you could have one doctor who goes with the AUA guidelines, another doctor goes with some other guidelines, somebody likes the American College of Physicians guidelines, and which one is right? And the question is that we really don't know that, and that's a conundrum to us. Next slide, please. So this is just really a picture of what happens when you diagnose cancer late. If you get these cancers early, certainly localized cancer in most cases at 5 years, 100% of people surviving. As you get away from the localized cancer, of course, you end up with a higher mortality. So our whole goal is to try to make an early diagnosis. For most cancers, it's always been said that if you diagnose it early, you do better. But there's some controversy about that with prostate cancer. And maybe we shouldn't be diagnosing prostate cancer early if we're going to treat people and have a lot of morbidity associated with the treatment, a lot of bad side effects for people who maybe don't need to be treated. Next, please. This is just a slide that sort of shows the morbidity and incidence for prostate cancer. The top line are blacks, and the next one is whites. And you see that line is way, way above the other ones. Next, please. And this is just sort of a tabular form of what I just showed you on the graph, that if you look at the incidence rates by race, all races, 154 per 100,000 men, white 146, but the black numbers, even though we only make up about 10 or 12% of the population, are strong enough and high enough to actually raise the total above the white, and although the whites are the majority of men in this country. Next, please. Same thing with mortality. Next, please. And again, you see that the mortality for blacks is more than twice that for whites. And these are NCI numbers. Next, please. So what is screening? I just mentioned that you want to pick something up early. You want to get it before it spreads. And if you can do that, maybe you can end up with better outcomes. Next, please. Is there a benefit to early screening? Again, we've taught that in cancer medicine, that if you get it early, you're going to fix some things, you're going to make things better. Not always the case. Next, please. So this is the piece. This is the thing that's caused all the controversy. This test that we call the PSA test, or prostate-specific antigen. Protein, glycoprotein, means it's sort of protein linked with sugar. It's elevated in prostate cancer, but elevated in a lot of other things, and therein lies some of the problems. That your PSA goes up, you get screened, but only 30% of the guys with elevated PSAs between 4 and 10 have prostate cancer. So how do you know who has prostate cancer? Well, there's some of those who say, well, because 70% don't have prostate cancer and 30% do, don't screen anybody. Well, that's great, because you end up screening the 70% who don't have prostate cancer, but the 30% who do are sort of lost. somewhere. Now, we recognize that a whole bunch of those guys who have, in that 30%, have indolent prostate cancer that's not going to kill them. But some of those guys have, in fact, aggressive prostate cancer, Gleason 7s and 8s and 9s, who are going to die in a few years if you don't pick them up. So if you tell people not to screen anybody, those guys are going to be lost, totally lost, okay? So we have to take a test that we understand some of the deficiencies of it and just make it better. Know how to use the test that you've got, but not throw it out. If throw out the baby with the bathwater means you don't screen anybody, and that's problematic. Next, please. This is the history. This test did not start off being a cancer screening test, okay? This test was developed at Roswell Park in New York, approved by the FDA in '86, and it began as a tumor marker to detect people who had recurrent cancer. But very quickly, you know, in the 90s, it started spreading out, and it became a cancer screening test. Now, there's some pluses to that, i.e. we're picking up guys at a different stage of cancer than we used to, but the downside is that a lot of people with indolent disease got treated, and they probably didn't have to be treated. And there were adverse effects associated with the treatments, and therein is a piece of the controversy and the big push in the press not to screen anybody. Next, please. Again, this is a quote by Jim Moeller. Jim has presented here many times. He's at Roswell Park. He talked about 25 years ago, the diagnosis of prostate cancer was the equivalent of a death sentence. And what he meant was that when you got it, you already had stage 4 disease. For most men, when they got picked up, they came in with back pain and other symptoms, so you could not cure them. So they were going to die. Many of them did not die of their prostate cancer, they died of other things, but you could not cure the prostate cancer. And you know, now we've got huge cures. The issue is the cure worth it? Is the cure worth all the side effects that some men are facing with the prostate cancer? Next, please. Again, prostate cancer history. We ended up with about 250,000 cases at the peak back in '92, and we're still running somewhere between 230,000 right about now, 235,000 every year. And but most of these cases are again localized. And there's some issues with the treatment. Next, please. So the deal is that when all this controversy started a few years ago, we weren't sure about the best treatments. There was controversy. Did it make a difference to screen? And as most of you in the room know, there were some studies that came out about 4 years ago, a big one in this country, the Pilco study, that said there was no benefit to screening. That when you looked at the guys who were screened and the guys who didn't get screened, they all had the same mortality rates. If that was the case, why screen? There's no reason to screen. You know, you're going to end up down the road at the same piece of the Y, regardless of which leg you start out on. So there was a big push not to screen anybody. Okay, next, please. The deal was that before this time, there was no clinical trial. So now you got a clinical trial, the Pilco study, and they said, oh, now we're going to take this test off the table. And that's when all the controversy started. Next time. Specificity. This is the only scientific piece I'm going to say here this morning. Sensitivity and specificity. Very important. It's about testing. If you got a test that you want to diagnose a particular condition, you want a test that's very sensitive. That is, it's going to pick up everybody who has the condition. Okay? Now, no test is perfect. Okay? No test is perfect. You get a test that has 90% sensitivity. That means that 10% of people who are going to have it are not going to get picked up by the test. Specificity. That means the test says you don't have it. No test is perfect. Okay? Some tests will say you don't have the disease and you know you got it. How many times have you heard a guy, oh, the test was negative, but I got this thing anyway. So this test is not perfect. So don't go and get a test and say, okay, I had the test and the test says everything is okay, because the test is not perfect. They all have some degree of variation in how good they are. And for the PSA, it is not a very sensitive test, okay? And not very specific. So it picks up a lot of guys who don't have cancer. We need a better test. Next, please. U.S. Preventive Service Task Force 2 years ago decided that they weren't going to screen anymore. Before that time, there was some controversy about screening. They were sort of on the fence about it, and so they gave, next slide, please. They had an eye, okay? Next, please. Because there was insufficient data. When they got the results of the Pilco study, next, please, they gave a grade D. That means that the task force, which is sort of charged with almost everything we do in this country in preventative health, they're the U.S., the quasi-official body that sort of decides who gets screened for this, who gets screened for diabetes, who should have their eyes checked, And the importance of what the U.S. Preventive Service Task Force says is that a lot of health insurers decide what they're going to cover based on what that task force says. So now they're saying, you know, we recommend that there be no screening. There's one little glimmer of light in there because it said if you're going to screen, and again they recommended against it, but if you're going to screen, there should be some discussion with the guy being screened about the pros and cons of the testing and what the outcome might be, all of the potential bad outcomes. They left that in there, but the recommendation was not to screen. Nobody, anybody. Now, that created a firestorm because there were groups that didn't agree with that. There are folks in this room who are going to speak to this, I'm sure. There were groups that didn't agree to that. Next, please. Here's a task force. This is from the chair of the task force. Before getting a PSA test, all men deserve to know what the science tells us about PSA screening. There's a very small potential of benefit and significant potential harms. So the task force is laying this out that there's a huge amount of harm with screening and very little benefit. And if you tell anybody, you know, if you got a scale and you weigh it this way, most of us are going to go with the side that has the most weight on it. Next, please. So, with the task force recommendations, other groups got into it. This is the American Academy of Family Physicians. They also got in line with the U.S. Preventive Service Task Force, almost in step, okay? Final recommendation, they totally agreed with it. Next, please. Here's the AUA, American Urologic Association, which looked at this a little bit differently. And they gave some grades. They said that based on information that we've gone through, and they commissioned a panel, independent panel, to look at this, looking at all the information, all the data. And we have urologists in the room, I'm sure they'll speak to this too. But they gave grades of A for that, for high, B moderate, and C low. Next, please. Guideline Statement 1, panel recommends against screening in men under age 40, and they gave that a C, very low. So for men under 40, we're talking about average risk men, there's no reason to screen. Next, please. 2, panel does not recommend screening in men between 40 and 54 at average risk. Okay? Now I'm really making it a point to keep saying average risk because the AUA had something to say about men at high risk. Okay? Next, please. Guideline 3, for men 55 to 69 years old, the panel recognizes the decision to undergo screening involved weighing the benefits, as we talked about. But they recommend that. They gave it a B for this particular group. In fact, this is where they hang their hat. The AUA hangs their hat on this particular age group, 55 to 69, because they think those people should be screened. Okay, next, please. To reduce the harm of screening, this is the interval. For some guys don't need to get screened every day. Depending on what your numbers look like, what kind of discussion you have with your doc every year, maybe you can get screened every other year, depending on what your numbers look like. Next, please. Okay. They do not recommend routine screening in men over 70, okay? Or anybody with a life expectancy less than 10 to 15 years, a grade C. Now, before I go to the next slide, I just want to say that the AUA looked at men at high risk, African-American men, men with a family history, and decided not to make any comments. They didn't have enough data. So the AUA, and you know, to flip away from what the U.S. Preventive Service Task Force says, say, well, we don't have enough data, so we're not going to make any statement about men at high risk, African Americans, men with family history. We don't know. We can't say that. Now, for us who are involved in screening, certainly a minority population, that's very important. But the AUA is saying that, but the sense is that not enough other folks are looking at it the same way. So we've got these, you know, guidelines from different groups, but they're not all saying, you know, for high-risk people, they ought to be looked at a little bit differently. We do not want to screen high-risk people in any sort of odd way, unusual way, so that they end up having more of the complications of getting treated for cancers that don't need to be treated. At the same time, we don't want to have those guys fall through the cracks. And that can very easily happen if you don't start doing some screening, recognizing that the biology here may be different than with the average risk person. Next, please. This is the National Comprehensive Cancer Network, and this is a lot of slides here, but they break the men down in different age groups, and they recommend screening, and they recommend looking at African American men, high-risk men, in a different way. That you ought to sort of take this group out, segment it, and say that you ought to look at this group because their numbers are so much worse. And, why is that? What is the biology behind that? But you don't sort of say that in this group, you don't screen. The key is you don't say that. Next, please. The next few slides, and we can talk about these offline, but the next slides are really NCCN sort of guidelines, but most of them are just what I said. The interesting piece about this is that they don't totally knock screening for men over 70, okay? Because keep in mind that a lot of guys, 70 years old, will live to be 95 years old. And if you got a guy who's 70, you don't screen, has prostate cancer, then maybe you're going to lose that guy, a lot earlier because he didn't get screened. So you have to sort of roll into this, the person's health history. What other issues are going on with them? How well are they? How strong are they? Is this a guy that walks 5 miles every day and, and has no significant illness? Because if he gets prostate cancer at 70, well, treat him. Certainly offer him the option of being treated. Make a diagnosis, what I should say. He ought to be screened if he's healthy. As long as you present to that patient, that man, what some of the risks of screening are, that you may have a cancer that doesn't need to be treated, that even if as the clinician who's taking care of you says you should not treat this cancer, Bill may still want to be treated, okay? Or Bill's wife may want him to be treated, or his family may want that, even if the recommendation is not to do that, and then he may be, of course, at risk for some of the bad side effects associated with treating a cancer that doesn't need to be treated. But the issue here, next please, just want to toss in the American Cancer Society, because they sort of left some openings. Again, didn't specifically speak to the African American in a way that the AUA did, but they left some openings about who should be screened. But the key here is that there should be some discussion about the treatment, the screening before you do it. And most of that now sort of hinges on, we're looking at programs now where we hinge on shared decision-making when it comes to this prostate cancer screening. And most programs are looking at, you sit down, you have a discussion with the patient about whether they should be screened or not, and then based on that discussion, you make a decision whether the guy should be screened. And most plans sort of say you should do that before you even offer the screening, as opposed to just doing the screening without any discussion and having a guy now have a test that's abnormal and getting into what should be done about it. So the big push to do that all over the country. We're working on a program in Boston with the state health department looking at shared decision-making with men at risk, where you sit down, have an educational session. So how do you do that in a 20-minute medical visit when you can spend 20 minutes talking about this? So we're working on ways to get some of the education done before the man gets to the doc. And he comes in having already been educated and now can have a decent discussion about whether or not he wants to be screened. Next, please. I think we're almost at the end here. But next, please. Again, go. No, American Cancer Society had a lot of stuff. Don't say anything. Next, please. Yeah, so what do we do? That's where we are right now. We got all this controversy, all these different guidelines, and some are not even guidelines. I didn't put the American College of Physicians up because they have sort of guidance, no guidelines, because the guidelines require a whole comprehensive kind of a look-see. But what do we do? How do we sort of get out the word that we want men at high risk to have a chance at having their cancers diagnosed, because we know if they don't, they're going to die. They're at high risk. They can't be looked at like the average male in the population. And that's our task, is how do we get the word out? How do we get media to look at this and sort of say, one last thing, and I'm going to turn this over to Professor Benjamin. I remember when they were going to come out with the task force recommendations, I got a call from one of the networks and for comments, and I made the comments, and I got another email an hour later saying, do you have anybody who's been harmed by screening? And when I got that email, I knew right away the tenor of the 6 o'clock news that day. I knew that particular network, which I won't mention, had already decided they were going to come out against screening anybody, and they were looking for some people who could go on screen and sort of say, we got harmed by the screening, and they found somebody, and they did that. So we've got some work to do for men who are at high risk, but I just wanted to sort of toss out this thing about these controversial, screening guidelines, and which one is right, and which one should we adopt, and how can we get these to have some sort of a consensus. And part of what Tom put together with the consensus statement a year ago was just this point. So, Professor Benjamin. Oh, no, you're going to introduce him. I'm sorry. Yes. Okay. Thank you.
Have a seat.
Thank you.
Dr. Carter.